Welcome to The Lead Climb, the podcast where we break down the strategies that drive patient acquisition and growth in behavioral health. Hosted by Growth Sherpa Consulting, we bring you expert insights on digital marketing, admissions, business development, and more, so your treatment center, mental health clinic, or private practice can thrive. Whether you're a CEO, admissions director, or marketing pro, this is where you'll find the tools to scale smarter. Follow us up the mountain. Let's lock in.
Awesome. Appreciate everyone joining us today for this new lead climb. Today I have someone I've known for a long time in this field, one of the first people I met at Foundations Recovery Network, Siobhan Morse. Siobhan, can you tell us about yourself?
Hey, Steve, thanks so much for having me. So I am the product director for behavioral health services, specializing in substance use and opioid use disorder for Universal Health Services, UHS. Specifically, I work most with Foundations Recovery Network and Foundations Health, but I also bridge the gap between all of our BH services and even some of the acute hospital services and SUD.
Awesome.
Do you want some background?
Yeah, please.
All right. So background is 12 years at FRN UHS. Before that, I worked feet on the ground in a treatment center for 6 years, did everything but drive the little druggy buggy. I have done clinical pharmacology research. I'm a certified clinical coordinator. I am a master addiction counselor. I have a master's in health services admin. I am an Arise interventionist, and I did a bunch of those. And I have 19 years in recovery myself.
Awesome. Well, so glad for you to join us. I want to kick off. We first met. I came from surgical sales, and so my sales day was you read a white paper. You're only allowed to talk about what's on the white paper to the doctor, and then basically you sat in surgery all day talking about your outcomes that you're allowed to talk about versus your competitors' outcomes. I come to Foundations. The first question I ask, okay, where's my white papers? Where are the outcome studies? And Foundations had them. A lot of our competition and other treatment centers out there did not. I guess what was so important back 11, 12 years ago for FRN to invest into the outcome studies and be really proactive in our industry at that time? And what have you seen like change and develop and grow in the industry since then?
Okay, that's a lot of questions, but let's go. Yeah, so I'm going to talk for a minute. Okay, so I'm not sure. So at the time, Foundations Recovery Network had Rob Wagner at the helm. Rob, pretty visionary in my personal opinion in terms of seeing what's coming and trying to prepare for the future in a strong, from a place of strength. And I got brought on to be director of research and Fidelity. That's what it was. I'm like, what was the title? Director of Research and Fidelity. So he knew about my research background, and the conversation was just beginning around a couple of things in the industry at that time. We were talking about value-based, right? Still hasn't really happened, but we're talking about value-based. And if you remember back then, a lot of people like you were moving over into this space, into the BD space, right? People from pharma, people from medical devices. We also had a lot of conversation. We were just tip of the iceberg of the opioid epidemic, right? The pill mills were just getting shut down. Like all of that was kind of happening. And so people who maybe normally would not, or in prior history would not have been going to treatment, were going to treatment. And so there was this whole new conversation of quality of care in treatment, right? So let me preface the next statement by, I am so grateful for all the wonderful people who are in recovery, who have open treatment centers, who have wanted to give back, and who have wanted to do the right thing. And nowhere else in medicine do you say, oh, I had heart surgery, I'm going to open a cardiac care center, right? You don't see that in medicine. And so, even beginning earlier than that, the whole addiction field and treatment began distinguishing itself with social models, with a more of a, the therapeutic community, 12-step. It was pulling itself almost out of medicine at that time. And so what part of what left were possibly some of the controls or the understandings or that just the medical view, right? So you had books like Inside Rehab and other things like that coming out at the time. And there was this big sort of cry of, wait, what's going on? Even though many treatment centers were Joint Commission accredited or CARF accredited, it's just you had some operators that were not operating, and probably we still do, right, in the industry, in any industry, that we're not operating as ethically as we would like. So research began, it started to fill a number of different roles, right? And at foundations, that's what I tried to impress on people. This isn't just so we have some cool white papers to market with, right? That's actually probably the least important thing that we can have out of this. The most important things are things like, hey, who are we seeing? What are their characteristics and how do we best serve them? How do we, take those like Lean Six Sigma skills and Deming management stuff, right? Total quality management, and begin to apply it to our field. And that was really part of what I was trying to do. So, constantly being in performance improvement. Oh, we see this. How do we work with that? How do we adjust? Remaining sort of in a very clinical sense, nimble to meet the needs of our patients. That really is what true individualized treatment, the basis of that is. Yes, I'm going to individualize it for that person, but anywhere in medicine, like you don't individualize care for every single appendectomy. There's about an 80%, right, expectation, and then the other 20% is what you manage. That's what sorry.
Yeah, I would say that's the exact case for the hernia surgeries I was sitting in on. You knew exactly what open inguinal bilateral hernia is the outcomes. You have 100 patients, one will have a recurrence. It was what it was. Like, it was pretty stable. But occasionally you get in there and you're like, oh, this person's anatomy, due to whatever reason, has some defects or flaws or things we need to navigate. I'll individualize the outcome for this person, but everyone else is pretty much the same. So yeah,
right. Well, the guy who weighs 180 and the guy who weighs 320, you're going to individualize care just slightly, but that 80% of that care, I mean, this is what a DRG, right, is, right? It's the care plan. We don't have those in VH, by the way, but you have a path. You have a predictive path. All the EHRs have what's called power plans because there's 80% of the time you can predict what the care is going to look like. And then there's 20% that's sort of the art of medicine, adjusting it for the individual. We never really thought of it like that, right? We also never really thought of it as, this is a long-term chronic disease. Addiction is, right? Substance use disorder, all behavioral health, long-term chronic diseases. Well, what's the mantra in long-term chronic diseases? Early detection, prevention, early intervention, right? All of those things. We don't really look at it like that from this side. So I began to start trying to use the data to inform those types of decisions inside of the treatment center. Outside of the treatment center, we used the data to say, okay, so what do our patients look for? What information should they have? There used to be this, I don't know, maybe Men's Warehouse or this place that sold suit. Oh, Size in South Florida, Size, and it was suits, right? And it was the educated consumer is our best customer, right? So what we started doing also is using this information to inform customers. Now, customers come in a wide variety. That could be everyone from very medically oriented referral sources. So we were publishing actual peer-reviewed PubMed. We had about 15 of those on different segments of the population and comparisons. We had a ton of white papers for the educated, informed person. And then we also just had a lot of content we were supporting just for people to begin to understand, to begin to learn, sort of moving that needle. There's also our payers, right? So we used these, all of this data, because any healthcare environment is a very data rich environment, constantly asking the patient, how about now? Constantly writing notes. Any therapist will tell you the boon of their life is all these things they have to write. But that's actually really good on the research side, because all of this is fodder for the machine, right? So that you can make informed decisions. But it's all data. Data is useless. when you ask a question of data, then it becomes useful. So we asked other questions like, what do policymakers need to understand so that we can have the right policy and legislative environment to provide good care? What do our payers need to know? What does really good treatment look like? What is the standards we should hold ourselves to? And so I actually went down a path of investigating the Agency for Healthcare Quality and Research. What were their 6 domains of quality in healthcare? And things came up like efficiency. We don't like to talk about efficiency, but using resources appropriately is an important indicator of quality of care. So that was, we just tried to build a machine that did all of that. The way we did that was we had an instrument, a survey, right, of about 121 questions. Each patient who came in was offered the opportunity to participate in our research program. We had a separate consent for that. They answered 121 questions on the way in the door. The Addiction Severity Index, things like the PHQ-9, the World Health Organization's quality. Yeah.
How long would that take? So I'm sure people are listening thinking, oh my goodness, 120 questions. Someone's just coming in the door.
The thing. Yeah. People walking in the door need to sign a consent and go to bed usually. Right. Yeah. So, we had the first 36 hours 72 hours, 3 days or so to complete that. And you could just do that sort of, hey, you got a few minutes, let's answer a few questions, right? Because it was all being put into the computer anyway, into a record. So we would do that. And the key there was that over 80% of people agreed to complete that survey. Then we wouldn't bother them with any of that again until 30 days after discharge. 30 days, 6 months and a year after discharge, we had people making phone calls to talk to them. It took 7 or more attempts, and we did texting, we did email links. We found that we got less than a 10% response rate on those. So it was really about phone calls. And we would, I think basically if you got through we ordered the questions so that if you got through the top 80, you were considered complete. Those were the most important things. But now we had over time, right? So I'm sure people are also saying, oh yeah, but they're telling you, they're lying. Well, NIDA checked that, right? NIDA did a big study, National Institute for Drug Abuse in the 80s, did a big study to see how often, it's called concurrent. How often does what the patient is telling you, what the family says, and what the urine drug screen says, how often do these things match? And they found that about 80% concurrence in post-treatment in surveys, right? So they're telling the truth 80% of the time, right? It is actually, there is some skewing young adults. It's harder to reach some people, blah, blah, right? But overall, you wanted to reach about 60% of people at the post-treatment time points, right? Those numbers all come from the Substance Abuse Mental Health Services Administration, SAMHSA, for people who receive grant funding. We were not receiving any grant funding, but that was the standard that we held ourselves to, and we were able to meet that.
So what about the other 40%? Obviously, if they're not picking up, how do you allocate for them statistically to make sure they're...
Basically, they're lost to follow-up. Because 80% of the time people tell the truth, what we basically said is this sample, we hit at least 60, we were often around 65%. This sample is generally representative. And the other thing we did is we were very honest about it. We were like, this information is based on 80%, whatever. Usually we're around 90 for intake because they're right there, right? So 90% at intake and 62% of patients or whatever the number was, right, depending on what we were reporting, completing the survey post-treatment at different time points. At 30 days post-treatment, we were at 75% compliance, right? Then it would drop down to like 68, 70, and it would be around 62, 65 for a year. And if you ask me only about, 18 to 25-year-old opioid addicts, I'm like, all right, well, it's not that good. Right? It's completely different. So
And so, I don't remember this specifically. Would you put a confidence interval or a p-value on that data so that you could say we have this X confidence in our study?
So in the publications, there are p-values and confidence intervals and all of that. In the general information and presentations that I would do, I would just be very clear. This is based on X percent, right? The key to the 80-60 is that in SAMHSA's view, that means you can basically it's reliable and it's valid, right? And so you can generalize to the population and say this is pretty much what we're seeing here as a result of this program or in these patients, etc.
It seems like a very fair threshold, right?
Yeah, and I mean, so since then, I mean, a lot of people, and it's hard. Like the first thing we would say to somebody who was interested in, and I went around for what, 3, 5 years, right? Telling people how to do this. Like, come on, let's all do this, right? But the first thing you say is, this is going to cost you some money because you're going to need staff, right? And so we didn't have clinical staff, no clinical staff on our team whatsoever, because I wanted the patients to feel comfortable. This wasn't about judgment. This wasn't about, oh, I need to say I'm doing really good because I don't want to let my therapist down, right? None of that. This was more customer service. Now, if somebody is, we always ask the question at the end, do you need any help with anything? Can we connect you? Are you struggling, right? But if they said no, it was no, right? And we did not give leads to the call center, right? It's the people that we saw had relapsed. We did not pass that information on because we promised these patients this would be, this would be firewalled. It would be separate, right?
Mhm.
So I feel like they felt we did everything we could to give them confidence in the confidentiality so that they could actually be truthful.
And that's a very big distinction point, I think, is that's one of the places for alumni. In what we do, alumni can be a admissions channel, right? It's certainly
Yes.
readmission. You did a good job. People want to come back, and that's part of it. But if you're looking for the fidelity in that word, you have to have that firewall, and you have to be true to that. And
Yeah.
I can imagine for some programs, say that firewall has to be a challenging decision to make because you have people you can help right there if you just pass them over to admissions. But for the fidelity component, you can't.
Right. Right.
That's tough. Yeah.
So, I mean, people are allowed to a certain point self-determine. It's really a very interesting conversation when you think about the overdose epidemic, right? If you wake up with a gun next to, if EMT comes and there's a bottle of pills, a bottle of alcohol, and or actually like a bottle of Valium, let's say, right? Or a gun and alcohol or something like that, and you're being called if you're being called in as a suicide potential, you're not going anywhere, right? You are right 72-hour hold. If you get picked up off the street after having overdosed for the 10th time, you can be like, yeah, I don't want anything, I'm out.
Yeah.
So no comments, just interesting, right?
Yeah.
How we still have that stigma, right? We're not seeing it as a disease.
And
We're
losing
seeing,
100,000
well, it's your
people a
fault
year.
anyway, right?
Right. And losing 100,000 people a year in America from OD.
Yep, every 8 minutes, right? During the course of this podcast, about 6 to 7 people will die of specifically of this, right? As opposed to, right?
Well, that's why I dig what I do. Getting to this line of work from surgical sales was cool because I saw as the better I am at my job, the more lives I could potentially save. And
Yep.
that's way cooler than doing one more hernia mesh and talking about a surgeon's new Audi. To be fair, it was a cool one when we had that conversation. I remember that was one of my last conversations. But it was pretty sweet, RS7.
Yeah.
But yeah, I think that's a fascinating thing about what we do is really are the front lines of a war we're not even knowing we're fighting and we're losing, and that's
Yeah.
each little component of it. So that's what I dig. I think about the outcomes part, and I think for our industry moving forward, it's a fascinating step to take to understand by each treatment center's own abilities, who do we treat best? Where do we have our shortcomings?
Yes.
How do we improve? How do we, market different or, train our staff different or have better or different facilities to support these folks? There are 7,500 or so treatment centers in America. I don't believe 7,500 have any sort of outcomes. All of them have all sort of outcomes. So you touched on it, and I'm going to forget the whole how does it come in the last 10 years. That's this long story. I like some practical stuff for this chat for people listening and watching is how do you get started? Sure, there's money investment, absolutely. Personally, I think that is money that needs to be spent. It's almost like having all the right compliance and licensure in place. You should have some sort of understanding of how your product and services is performing. But can you walk us through maybe what are the first steps for someone who has never done this before to take?
So the first thing that I would do is not even a sort of a research basis, right? First, I'd look at like, okay, so what are we doing, right? So way back in the 80s, Robert Woods Johnson Foundation listed 5 things that it became what are known as evidence-based treatment, right? Are we using those principles? Are we staying true to those principles? So is my staff trained in CBT? One, right? Is my staff, including family, not just biological family, but the entire, what the patient feels is family in this conversation? As part of the treatment process. Am I doing medication management and am I doing it well? Like medication management that's sustainable. There's going to be, in the beginning, it's going to be a higher level of medication because you've got the stabilization period. But over time, you need to come to something that's sustainable, both financially and just mentally and physically for this patient. It can't be this giant handful every day. Right? This person's going to be out in the world. They need to be able to function in the world. So there's the whole medication management. Then I would look at how well am I doing at holding on. The other 2 pieces to me are how well is my dual diagnosis performing? And you could assess that. There is what's called the dual diagnosis capability and addiction treatment toolkit, right? So you can assess that. And then also looking at how long am I maintaining patients, right? Those would be, I think, 5 of the key things that I would want to look at. One other thing I might do, especially if I'm Joint Commission or CARF. Joint Commission and CARF requires that you do at intake and at discharge some outcome thing. It doesn't really fit for like a res. Of course they got better. They've been here 20 days or something, right? But that's fine. What it will tell you is a lot of what you're talking about. So 1, it'll tell you the severe, if say you're using PHQ-9 and GAD-7, 2 very free tools. One looks at well-being and depression symptoms. One looks at anxiety, very common co-occurring within the addiction substance use population, right? So if you're doing that at intake, it should inform the treatment plan. Joint Commission and CARF will check that it does, but it should also inform your programming. All right, so I've got patients who have a lot of anxiety coming in. I think I might need to start some groups that talk about and normalize anxiety. You know what else I could do? I could start groups that help give patients tools for anxiety. And I need to make sure that these patients that have high anxiety are actually receiving the meds they need to help manage that anxiety. So you build it into your performance improvement program in that way. And what you're basically doing is now you're doing sort of individualized care because you got that 80% respond to CBT, right? All of that. And you're looking now individually at your group and saying, oh, I have a group, right? A large percentage of this. So I need to pivot just a little bit. Like my hernia practice seems to have all over 250-pound people. All right, we're going to have to add something to the normal course of hernia care for my practice. And, I've got a group that also, I don't know, is diabetic. I don't have any idea. I've got 5 people that are diabetic. Well, the diabetes might be contributing to their weight. So for those 5 people, or as they show up, I will also have in my back pocket a conversation to help them with that. You see? So that actually is how you do individualized treatment. It's not like starting from an empty slate every time you see a patient. That doesn't make any sense because you're going to have too much variability between therapists and between, you won't have any standard of care. That was the big thing that we were looking to create at Foundations, was this idea, and that we have, at UHS now in our Foundations facilities, we're really working on recommitting to it, right? Is this standard of care that we have, this basically the concept of that 80%. Like, we know this is what works. And in fact, we did the research showing that it worked really well in our patients. So minor adjustments for different groups across the different facilities, but in general, here's sort of the 80% rule, right? Everybody will receive this as the baseline. This is the minimum threshold, right? The standard we have, the system. And then we will individualize for the individual variations within treatment centers and within individuals. So again, the 5 things. Let's look at the evidence-based, what SAMHSA, what Robert Woods Johnson Foundation talked about as the evidence-based practices, right? So we'll look there. We'll then go to the dual diagnosis capability toolkits. They have one for mental health treatment centers and one for addiction primary treatment centers, right? This all came out of Dartmouth. It's a guide. There's an entire guidebook. It's all based on Tip 42, which is the co-occurring treatment Bible, which came out of SAMHSA. But it'll help you assess, and it'll give you suggestions to help you improve in areas that you're lacking on the different cultural system and process pieces of your treatment center. And then, finally, using that data that Joint and CARF said you have to collect anyway, and beginning to really get an in-depth knowledge of the populations that you're serving and what you can do to help them. After that, then it gets a little more expensive and complicated in terms of doing some longer term outcomes. But once you get a system in place, you can do what we did is a 5-year study. And as long as we're using our system, there's no need to redo the 5-year study. We know it works.
Well, here's what I like about that too, from a business side of things, right? So if you have your system and you have what in many cases is your target treatment plan. So you're gonna have an idea of the demographics and the personnel who are people who are best, the patients who are best to come in there. So you mentioned diabetes and overweight for hernia.
Yeah.
Smoking is one of the big ones for any
Yep.
sort of surgery. For recurrences, actually I had a family member recently who had to give up smoking for like 2 months prior to his surgery. He was in awful pain, but they wouldn't do it otherwise. So all I have to say is there's clearly opportunity for exclusionary criteria for clientele. A lot of who we work with is clearly front end. We have admissions, marketing, and outreach personnel who have the first touch with all potential patients, that top of the funnel patient mix that is literally everybody in some instances, that ends up coming down to that more ideal or targeted or matched client for the system of care. I think there's a great opportunity for treatment providers to use the information they get from their telephony systems and CRM on the front end for their denials to see, are we actually having those first line calls who are meeting, or is there a huge amount of people who are trying to come to our treatment centers that we could treat with some new changes or diabetes tracks or
actually, are we treating a population that's way sicker than the criteria, and therefore we should be seeking enhanced rates?
Amen. Or referring to places that can handle them, right?
Right. Do I have appropriate referral sources for those patients I can't handle? Right. And no, 100%. There's one other thing that is probably the single most common, right? The one thing that is tied more to outcome than anything else in the literature is the length of engagement. Notice I didn't say length of stay. I don't care how long they stay in your reds, right? But how long are they remaining engaged in a continuum of care? That's what really matters, right? So that could look like a single continuum. It could look like a community continuum. It really depends. So in DC, for example, where we have Psychiatric Institute of Washington, and we have George Washington University and another acute hospital opening up, we're not doing the 30-day treatments, right? That's not us. But we're working so close using peers, partnering with different community members, and helping other people open those pieces and parts that need to be there, like respite housing, all of that, so that people, once they come in that emergency room or once they hit that access center at the psych hospital, they now have a long-term path. And then helping them stay on that path. And peers are probably the best way to do that, is keep people on that path. But really, when you think of it from the payer perspective, what the payer is like, the biggest issue of the payer is, where's my patient? Where's my patient? They missed an appointment. Where's my patient? You discharge them. Where are they? When am I going to see them again? And how do I ensure that we're going to see them again so they don't end up back in that emergency room?
So I love this because a lot of times in the last 10 years doing 11 now years doing this, I think the majority of feelings around discharge is a business model, primarily clinical next, right? You're finding out who your referral partners are in the space, and then you refer the patient to whoever refers back to you. Very common practice. I'm not agreeing with it, but I'm saying it's incredibly common by all means. But I think what we're missing here is the bigger picture, right? If you have a system built out, let's say in your CRM, where you have a patient matchmaker, and you can now appropriately refer a patient to all different levels of care and support systems, like you said, housing, peer support, aftercare, vocational, if not, like you have everyone in there, and you can then very easily track John Doe, Jane Doe went to this sober living home, they're working with this peer support specialist, they're in this community program, etc. From a build out standpoint for a program, it doesn't take a heavy lift. I mean, I do those in a week or two sometimes, and they're super easy to train on. But what the bigger picture for a business should be is now our patients get better outcomes. We have better, better things we can then bring to the payers and say we have friends, family of that alumni will say now want to get referred. They're the first choice of referral for that person.
At foundations, roughly 40% of our admissions at one point were coming from not from former, it wasn't readmitting former patients through alumni. It was admitting friends of former patients through alumni.
Yeah, and that's what a great testament is that. And from outcomes, typically people associate with people similar to themselves. So if they're getting great outcomes, they're in the program, they will fit. So from a business standpoint, it's not a heavy lift to have that front end data collection to say this is who is inquiring about our program. From the discharge side, it's not a heavy lift to say this is where we sent them and how we're going to stay in touch with them moving forward. It's just getting that process rolling.
Well, so there's when you think of it from the acute psychiatric hospital and from the ED, right? You've got referral, which means you told them where to go and you set up the appointment. And then you've got linkage, which is confirming that they made the appointment or helping find them if they didn't. Most facilities do a great job with referral. They do nothing on linkage, right? And when you look at tip 42, when you look at what SAMHSA, Substance Abuse Mental Health Services Admin, recommends, it's assertive linkages, right? An assertive linkage. So if you haven't started thinking about peer navigators yet, you may want to consider thinking about peer navigators. And at the end of the day, there will be a point at which there are bonuses for people who have patients who are not readmitted, right? Now, we did a lot of that whole alumni thing and the referrals, alumni referrals in such a high rate with a travel treatment model. Most treatment now is much more local, the way that the industry has gone, right? It's much more local. So if you are, just think about the opportunity. So we've begun opening a series of OTPs, opioid treatment programs. That is almost 100% word of mouth. We still need to do some court liaisons, do some billboards, things like that. A little web-based stuff, but it's not like, res treatment that it's so much SEO work and all of that. This is much more of a local referral network, and reputation management is everything at that point. So you know what? I'm so grateful that they were there for me, able to help me stay in treatment long enough to get this, even though it wasn't just with them, right? The tagline for Foundations Recovery Network has always been lifetime relationships for long-term recovery. It's not just with our patients. This is about, the antidote, right? To any substance, to any addiction disorder is connection, is relationship. And so this is relationships with payers. This is relationships with other providers, with community support, with all our social determinant, providers out there in the community, housing, food security, job security, education, transportation, right? All of that. to be honest with you, like the goal is in a local setting, especially if you're looking at a Medicaid type population, to be able to help them meet those needs. Because the truth of the matter is, ain't nobody care about treatment if I don't have a place to. If I'm couch surfing, like maybe I'll make it, maybe I won't. Thank you for not letting me die on that on that particular day. But yeah, I gotta handle all this stuff first. So helping people get those connections, right, is a huge part of what the sort of the modern treatment center needs to help with. And quite frankly, even in that treatment, the travel to treatment model we had, how often did you have these people who came from really well-off families and they were out of money? They had nothing left. Like families, nice middle-class families who had taken out 3 mortgages to help send their kid to treatment that many times, right? There was just nothing left.
Awesome. So Siobhan, I'm gonna ask you something. We haven't talked about this before. I'm a giant nerd about this, so I'm really excited to hear your standpoint, good, better, or worse. Okay, this is even pre-AI. I got to be a fan, but I think AI has kind of changed the dialogue around this a little bit. I'm a big fan of predictive analytic opportunities in behavioral healthcare. I think there's enough data points from treatment centers, especially very large
I've
programs.
used it.
Let's
Okay.
talk about it because I think it's underutilized.
You don't even need AI.
Yeah, so let's talk about it because I think it's underutilized. I think there's a great opportunity for finding patient demographics, making the call, more likely to relapse in other days. Okay, so cool. So tell us about it. What's going on?
Okay. So you asked, you want to talk about predictive analytics, right? So that's the prevention aspect, right? That's the public health aspect, identifying who has what needs before they even have those needs, right?
Yep.
So it's the same thing as saying, if your mom and your dad both have alcohol issues, we probably need to put some services in place to help prevent you from going down the same path as a community, right? Not the treatment center's job, but as a community. So here's what we did. And we didn't, this was pre-AI. This is literally, in fact, even, wow, a long time ago. Some basic statistical programming will help you with this. We did, and this is even pre-FRN. This is late 80s. We looked at a population in Kent, Sussex County, Delaware, of mental health needs, people with mental health needs. And we backed into the top 12 questions we needed to determine the probability that they were going to have a crisis episode and to be able to prioritize those patients. Right? The same concept. So what we did at FRN is I had a facility that was really struggling with patients leaving AMA, ACA, and I can't help you if you're not here to be treated, right? AMA is leaving against medical advice, ACA is leaving against clinical advice. So these patients were like, once they felt better, they were kind of like, I'm out, I know, I'll go to meetings, got it, I'm out, right? And it was very, very frustrating. So, excuse me, we stepped back and we said, okay, so what makes these patients, this handful of patients, different from everybody else? And we found a couple of things. I'm not saying this is applicable everywhere, but this is what we saw in that study. And this is basics, just really some descriptive and simple statistics you can do with your Excel spreadsheet, right? We found that on the way in, males who were overly preoccupied, like meaning they really were concerned about getting back to work. I just need to get better. I got to get back to work, right? Or they were very worried. I've lost so much money this year at my job, or I'm going to lose my job, or that conversation. And we actually specifically had some questions that asked about how troubled or worried are you about your finances and about your job at intake, to be able to look at that. And we found that they were likely to leave early. And we had 2 other groups that we identified as well. But so then what we did is we targeted, okay, so anyone who answers, I'm very concerned about my job, I'm very concerned about my finances on the way in the door, we have a set of interventions that we're going to do on them regardless. We're not going to wait till they're like, I got to go, I got to get to work. We're going to have a set of interventions. We're going to do things like we're going to talk to them in their business language, and we'll do a cost benefit analysis of staying in treatment. One of the first assignments they'll have. We'll be speaking to them like that. We will, and we will continually represent the what fors, of staying in treatment, the benefits, right? Because they're going to focus on the cost. We will continually be present to the benefits. We will also allow them over time to earn the ability to do some of their work, to earn time on a computer, or right, to get some things done so they can feel a little bit better. And so we did for that population. There were two other main populations that we identified, and we did similar things for them. And we were able to drop the rate. Gosh, it ended up being about 20% of what we started at. So huge 80% drop in the people leaving treatment early as a result of being able to predict who was going to leave early and put in prevention and early detection, right? And then putting in prevention and early intervention strategies to help mitigate the need to leave early. We also did things like just generic groups, like we said, well, a lot of people struggle with symptoms. Let's have some more symptom conversations in the beginning so that it's normal. So you don't think you're the only one going through this, right? And let's put some rewards at the end of those, right? And it was extremely effective. But that's AI. That's really the AI predictive analysis conversation.
Well, and we get calls all the time, have since we started this, and the whole goal is, can you make the phone ring more? And absolutely, sure. But what I've come to find out is not necessarily that people want the phone ring more, but they want more revenue for their treatment centers, and rightfully so. You got to keep the lights on if you want to treat someone, right?
Yep.
But how is
No margin, no mission.
But how's an 80% drop in AMA helping revenue? Average length of stay goes up, number of admissions needed goes down, outcomes go up. Then you have better
cost per admit goes down huge.
Cost per admit goes down. You all of a sudden now have more opportunity to treat people in house, and I gotta tell you, from working in some lower or some higher levels of care that have shorter lengths of stay, it's a headache when you have someone in and out the doors in 3-4 days, and you have 30 of them in and out the doors in 3-4 days. And from a business side, it's an absolute headache, because then you wake up on a Sunday morning and go, we're census, and then you have to figure it out all of a sudden. But then from a human side of things, like you said earlier, I always say, all things equal, longer length of stay equals better outcomes. And that's just
that's the number one predictor. It's not even what type of treatment you went to, how intense, what the clinician's credentials were, none of that. The number one predictor of a long-term outcome is actually staying in treatment longer. The most magic, more is better in that case, but not more intensity, just more engagement, longer engagement. And we actually did some work on that as well. I did a quick study that looked at young adult males. And what we saw is the young adult males that went from res to IOP with housing, like to PHP and then IOP, did a full step down model, actually had much better, less depression, less anxiety, less aggressive behavior, right? They, on a number of indicators, they did much better at the 6-month mark than their counterparts.
And since a lot of people in business development watch this and listen to this as well, I think from my personal experience working in the field, it is a lot easier working with referral sources when only 1 out of every 20 of their referrals to you leave AMA versus 1 out of 5.
Yes.
If you get to that 20% AMA rate from referral source referrals, you don't have that referral source anymore, or you shouldn't, because if I'm a referral source and 1 out of every 5 I'm seeing is leaving on day 4, something's not right. I don't have that trust, very trust-driven industry. So from helping support the whole ecosystem of front-end patient acquisition, that does it, and the data's there, and you just have to use it.
Yeah.
Forget it, then use it. So that's wildly helpful on the front end. And I know most programs are going to look at that as a clinical outcome, as they should, but from a person who lives and works on the front end day in and day out, I feel so much better in the field talking to people about AMA rates that are reasonable and above industry standard, lengths of stay that are strong and good, and outcomes, because then you actually have a predictor. And For me, I find it just fascinating. This industry has always been fascinating to me that we're still, and I can't find another one that doesn't know how they get their revenue and doesn't know how good their product is, but it stays in business. And it's just so fascinating to me that it somehow happens. Like my dentist doesn't do that. He knows exactly where it's coming from and how well his root canals do or whatever. Luckily, I haven't had to have any of that, but yeah, it's interesting. So awesome, Siobhan. This has been great as always. What's one piece of advice you have for everyone listening?
Okay, so if you're a BD rep and you're working with a treatment center and you're looking to do patient acquisition activities, I think anything that you can do that points to data, but be honest, right? Don't do this based on 40 patients when you know your treatment center sees 700 a year, right? I mean, and if you only base it on 40 patients, say we're just starting, be honest, right? I've seen these documents where they talk about how great they are, and then they have this in very light gray at the end, tiny print. And I mean, I'm looking at 2% of your patients here. And you tried to trick me into thinking it was more. I don't trust you now. That's just me. And I think that's an issue, right? You have to be honest. So I would say start playing with your data. Start looking at, okay, who comes, even if what you start reporting are things like the stuff that you're already giving to Joint Commission, right? That's fabulous. So our patients have a reduction in their depression score by 10 points, right? Based on 72% of the patients who came to us, right? And based on an average length of stay of 7 days, whatever that looks like, right? Start kind of looking at things like that. But the biggest thing in all of this, right? Because everybody wants to have data and use it, is tell me, please, this is my pet peeve. Don't tell me what your success rate is, because I don't know what that means. Right. My payer has a very different definition of success than does mom. Right? So the payer just says that means people didn't have to come back to you. Mom says, I got my kid back, right? Different. Tell me what you're telling me. So reduction in depression scores over an average length of stay of 7 days in patients 18 to 24 at our treatment center. And then at the bottom, you put based on 60% of patients. Now I know exactly what I'm looking at, right? And that gives me faith in one, you know what you're doing and what you're talking about. You understand what matters, and you're honest. That goes a long way in my book for building a relationship.
I agree. And I'd like to add one thing too is if you've never marketed outcomes or data in a medical or scientific form as a marketing role, take it slow, ask for help, and don't assume people know what you're trying to explain to them. So everything you just said, absolutely. And I always like to say, and then compare it to national average. So like people have a gauge or an understanding when possible to say this is based off data sets or based off of our thing. So I think that from a data standpoint, the data marketing is while important to be truthful, honest, but then don't assume everyone understands the full context of things and help them get to that point. Because this can go many different directions in our space for these things. So for sure. Awesome, Siobhan. Appreciate you. How can everyone find you? Awesome, Siobhan. This has been great.
Siobhan Morse at uhsinc.com.
Awesome. We'll add that to that. And if you have stayed and watched this entire thing, thank you. That's because you're awesome. So of course, the whole thing is like, subscribe, pass to your friends. All that stuff is super helpful, but appreciate you staying, listening, and watching as long as you did. Siobhan.
Yep.
Awesome. Great.
Thanks. Take care. Bye.
That's a wrap for this episode of The Lead Climb. We hope you picked up some valuable insights to help optimize your patient acquisition and grow your behavioral health organization. If you found today's discussion helpful, be sure to subscribe, leave a review, and share this podcast with your network. And if you're looking for expert guidance in digital marketing, admissions, business development, or any other piece of the patient acquisition puzzle, Growth Sherpa Consulting is here to help. Visit us at www.growthsherpaconsulting.com. Thanks for tuning in. We'll see you next time on The Lead Climb.